is biomarkers in pre-diabetes. Yeah, so quick 20 minutes. Now we've moved from a very clinical session since morning, and it's going to be a very dry session, honestly, let me tell you. So if you want to take a quick nap, you're ready to do that. But I will put some 2 questions in between, and they'll be very random questions. 10 years back, I would call them as Cadbury questions, but I think that's forbidden now. So so the topic, what I would go through is a quick introduction. It sounds superfluous at the end of this, towards the end of this day. What are the traditional biomarkers we have today? What are the new ones on the horizon? And what do we have in future for future's early detection and early intervention? Next slide. Thank you. Okay, thank you so much. Yeah, so we have seen this talk from Dr. Mohan's slide. He said it takes you ages to develop diabetes. Diabetes is not something which happens overnight. It takes about 8 to 10 years, and we know that first half by the time, 0 is the point where a person is detected diabetic, and by that time, if you see on the y-axis is the beta cell function, which is your insulin reserve. And by the time a patient is detected diabetic, 50% of the beta cells are gone. Now, previously we used to think that they are lost, but today we call them dysfunctional. And this goes back to Dr. Mohan's talk where he said that we can use this years, this is called as the pre-diabetic years, we can intervene there and probably back into the normal category and a lower risk of diabetes and its antecedent complications. This is point 1, which is the major concern. Second important, why is pre-diabetes important? This is a period of silent period of high glucose levels, mild elevated glucose levels, but these mild elevated glucose levels are cytotoxic. Dr. Joshi, Shashank Joshi sir said about mitochondrial dysfunction. Very true. Free radical damage. Very true. This is the silent phase where mild hyperglycemia is going to interfere with the mitochondrial function. And how do we see this in clinical practice? You actually go back and see in a diabetic population, about 20 to 50% of newly detected diabetics have neuropathy. Where did they've just been detected diabetic, but where did the neuropathy come from? It was that silent phase. About 10 to 15%, 15 to 30% have retinopathy and diabetes diagnosis. About 2 to 5% have nephropathy. Imagine a newly newly diagnosed diabetic has CKD. So, we've missed a lot of time there. And about 5 to 20% of newly detected diabetics have heart failure diagnosis. So, this is a very important, probable tip of the iceberg which we have to detect, pick up, and intervene early. And of course, pre-diabetes is considered as a marker of insulin resistance, and associated factors like hypertension, dyslipidemia, fatty liver, or rather it's called as MASLD. It's no longer NASLD, it is MASLD. High uric acid and high cholesterol. So how do we diagnose diabetes? We all know this is a by heart slide. We look at your fasting, we look at your 2 hours post-glucose, and we look at HbA1c, which today for all practical purposes, the ADA gives it as the gold standard to diagnose pre-diabetes as well as diabetes. But is this the full truth? This is a very busy slide, and I have been interested to speak on all these biomarkers in diabetes. It's a PhD thesis topic, and to cover in 20 minutes is gross injustice, but I'll try to do my best to touch upon what are clinically relevant. So, to sort of divide it, what we have is the traditional biomarkers and the newer biomarkers. I'm going to restrict these biomarkers to type 2 diabetes. I'm not talking about type 1 biomarkers because that will involve a lot of antibodies, which is beyond the realm of this 20-minute talk. So what are the traditional biomarkers? We have HbA1c, we also have fructosamine, glycated albumin, and 1,5-anhydroglucitol. So HbA1c, we all know, we use it in a clinical practice, and thankfully 10 years today down the line, at the beginning of this century, how many of us knew about HbA1c? How many of our patients knew about HbA1c? Hardly any. Today, almost every third diabetic is aware about HbA1c. So it is considered as a gold standard, and it's a good tool to apply to the population because it's a strong predictor of diabetic micro and macrovascular complications. It's very convenient, it doesn't need fasting, it is a good stable test, especially when you do it by the HPLC assay. Remember, there are many assays, many platforms which can estimate HbA1c. And when you look at a report, look at the test, look at the methodology. If it's HPLC, that's a good test, because there are many laboratories which use basic RIs, enzyme-linked assays, which are not still very standardized, and they're subject to a lot of errors. And that's why you have a Mumbai diabetic and a Jodhpur non-diabetic. So if you remember the joke from morning time. And so of course HbA1c does have minimal day-to-day fluctuations. But coming to the pitfalls, everything is not lovely and wonderful. When you compare HbA1c to fasting versus and the OGTT, it is not a very sensitive parameter to pick up pre-diabetes. The correlation is just about 50%. So you can miss a huge chunk of population if you used only HbA1c to diagnose pre-diabetes. Also, as Dr. Mohan said early morning, it is affected by ethnicity, age, sex, race, and HbA1c cannot be uniformly applied to all populations across the world. And most importantly, changes in hemoglobin levels can affect HbA1c. You have conditions where the A1c could be falsely elevated, like chronic anemias, folate B12 deficiencies, very rampant in our population, severe hypertriglyceridemia. All these can falsely elevate A1c, and you have falsely low HbA1c conditions like pregnancy and hemolytic anemias. Hemoglobin variants, very common in our country. Some populations, look at the Western population, look at the Far East population, they have hemoglobin variants. And these patients, the HbA1c is not a very good parameter for them. So we need to look at other tests. So what are the other tests which are currently available in the market? The first is fructosamine. Fructosamine refers to glycosylation of fructose to the total proteins, especially serum albumin. And it is a marker of short-term glucose control, about 2 to 4 weeks time. So it will help in patients where you think patient has diabetic complications, but the A1C is 6.5. You are unable to explain that. So maybe fructosamine would serve as a better assay here. In conditions where the hemoglobin is fluctuating, where you cannot rely solely on the A1C, the fructosamine is a good tool to fall back. Fructosamine is a good risk for microvascular complications, and it's cost effective and convenient to perform. But the problems do exist with variability in the test within the subjects, and again these are subject to both false high as well as false low. Also, there's no specific cutoff, like where you have an A1C, you have a cutoff of 6.5. Fructosamine, these cutoff levels have yet to be established and validated. Yet, in one particular patient, you can use the fructosamine as an alternative to HbA1c. Similarly, glycated albumin. Now, glycated albumin is better than A1c because of the same conditions like fructosamine, where it doesn't depend upon the hemoglobin. It's especially useful in patients who have abnormal hemoglobin levels or high or low hemoglobin levels. It quantifies the albumin the GA to the total albumin. It's not it's not to the total proteins. It's to the particular serum albumin concentrations. So it's better than probably even fructosamine, and it serves again as a short-term marker. But again, it also has its own disadvantages in terms of being artificially low in patients with a high BMI or high body fat and high visceral fat. Similarly, 1,5-anhydroglucitol. So these are new molecules which are there, which commercial laboratories are running these tests, but they yet need to be standardized and applicable across different populations. Again, this is it's a molecule which estimates short-term glucose fluctuations, stable and reproducible, but variability remains a concern. So, putting in short, it is a tabulated form which compares fructosamine, glycated albumin, and 1,5-anhydroglucitol. Now, coming to something which is interesting, which is novel biomarkers, and here comes the role of metabolomics. So what does metabolomics pertain to? So, these are metabolites of carbohydrate, protein, and fat metabolism, and these metabolites, downstream metabolites, the ones which are studied, which interfere with the insulin regulation and insulin signaling, and eventually leading to glucose dysregulation. So, estimating these metabolites in the blood is called as metabolomics. Similarly, estimating the Protein molecules in blood is called proteomics, and then looking at the gene studies is called genomics. So a few molecules which have come up in recent times are fettuin. So fettuin is an interesting molecule. It's a glycoprotein which is secreted by the liver, and this induces insulin resistance. I had a pointer, I could have pointed out, but the top, so basically it interferes with insulin receptor. In the top one, you see the red fettuin, which actually blocks the insulin receptor and prevents the tyrosine kinase signaling. What it does, it activates the TLR4 receptor and stimulates the lipid-mediated insulin resistance pathway. So this is a novel mechanism which has been used, and actually there are studies worldwide which have looked at correlating fettuin A with increasing risk of obesity, insulin resistance, and cardiovascular disease. So it's an interesting, promising molecule. Acylcarnitine. So we know that these fatty acids in the cytosol need to move to the mitochondria for energy production. But when there's excess accumulation of fatty acids within the mitochondria, within the cells, in the cytosol and in the mitochondria, that leads to oxidative stress, mitochondrial stress. And acylcarnitines are byproducts of these metabolisms. So again, there are studies done with it. So estimating serum acylcarnitine levels is known to be a predictor for insulin resistance. Abnormal fatty acid oxidation and mitochondrial function leads to accumulation of intermediary products like acylcarnitine, which promote inflammation and insulin resistance. Ceramides. Where do you see ceramides? Ceramides are a part of your cell walls. They are sphingolipids. Okay? They are natural, they are important constituents of your cell membranes. But again, abnormal accumulation of ceramides in the cells, it disrupts a lot of cellular functions. So what does it do? It interferes with insulin signaling. There are mechanisms for that. They interfere with glucose uptake, impair nutrient storage. They are pro-inflammatory. They can disrupt lipid metabolism, and they can cause cell apoptosis. So in fact, there are these levels which studies have shown the ceramide to palmitic acid ratios is an independent predictive biomarker for new onset diabetes years before diagnosis. So it could be used, ceramides can be used as a marker for pre-diabetes, and in fact, ceramides are accessible in other body fluids. So they are now being evaluated as markers for Alzheimer's. They are used for markers for multiple sclerosis. So interesting molecules on the horizon. Similarly, natrin is a protein. It's a laminin-related protein. It's produced in it's expressed in various tissues of your body, the central nervous system. Interesting area would be the pancreas. So because it's involved in pancreatic morphogenesis, abnormal natrin levels may have a role in diabetes. So in studies have shown that natrin levels are significantly increased in patients with IGT or type 2 diabetes compared with the control group. So it could also be used for as a marker for diabetic microvascular complications. The list goes on. I'm sorry, I told you it's a very dry topic, but yeah, maybe one of your students may perform a thesis on this. It's alpha hydroxybutyrate. Again, this is a catabolite of protein metabolism of threonine, methionine, and glutathione. Shifts in these mechanisms lead to elevated levels. And elevated levels of alpha hydroxybutyrate are associated with worsening insulin resistance. And again, studies have shown that normal glucose tolerant, insulin sensitive patients have lesser levels as compared to NGT, insulin resistant patients. So, yeah, thesis topic next. Now, this is a tongue twister. Who can pronounce this right? Linol glycerol phosphocholine. I prefer to call it a simple one, LGPC. Okay, so yeah, linolene glycerol phosphocholine, LGPC. So till now, whatever molecules we said, they were all elevated with insulin resistant states. This is a negative correlate. So in insulin resistant or obese subjects or type 2 diabetic subjects, this is negatively correlated, meaning these levels are low. Similarly, adiponectin. Adiponectin is a good cytokine. I hope you've heard about this molecule. You have inflammatory cytokines. Most of them are bad. Adiponectin is one of the good cytokines in your body, and it is a marker of insulin resistance, and you can use it, and there are plenty of studies across the world which have looked at low adiponectin levels associated with insulin resistance. Then comes amino acids. Amino acids are good for health? Yeah? Yeah. Yeah, that's what I thought till I actually picked up reading in depth about it, and then I'm like, oh my god. So as I run for marathons, I take my supplements in between on and off. And then I'm shocked to find that BCAAs are not really good. And that set me deeper into the research. So amino acids are good for health, but there is this worry with BCAAs and aromatic amino acids which have been shown to be associated, strongly associated with inflammation and insulin resistance. How the mechanism is still not clear, probably works through the mTOR pathway. Again, studies have shown these resistance levels to be high in patients who are obese or who are on a high-fat diet, but the bottom line is still not out as yet. Now, it made me wonder whether we use leptin. Leptin is supposed to promote insulin resistance, but we see high leptin levels in insulin-resistant subjects. So, is this a cause or a marker? We still don't know. But yeah, technically, BCAAs and aromatic amino acids can increase insulin resistance. MicroRNAs are another. So, they are small gene molecules, protein, non-coding RNAs. Again associated with diabetes. So trying to put everything in a nutshell. Sorry. Inflammatory. Are my slides in this? Oh, okay. So inflammatory markers. Okay. No, so I'm looking here and saying. So I think. Okay. So inflammatory markers was basically interleukins, CRPs and all, and these have been shown to promote insulin resistance, and everybody aware of that. What is the lipid-IR connection? Dr. Kapoor had mentioned in his talk, a low HDL, high triglycerides are markers for insulin resistance. Similarly, high lipoprotein A, which is very common in the Indian population, is again a marker of insulin resistance. Ferritin and transferrin. Okay, so you know what are the pathophysiological, how many pathophysiological mechanisms for type 2 diabetes we have today? In my time, last century, we had only two parameters, insulin secretion and insulin resistance. Anybody aware of how many mechanisms have been added to it? There were two, it went on to the octet, and today we have 16 pathophysiological mechanisms for type 2 diabetes. So ferritin and transferrin come in here. Iron overload is dangerous for the beta cells, and also iron deposition, excess iron deposition in the cells can lead to insulin resistance. It leads to both beta cell secretory defect as well as interferes with insulin glucose uptake at the muscle level. The vascular connection, the angiogenic connection, plenty of molecules, fibrinogen, hematological indices like thrombospondin. Don't even ask me the full forms of this GPLD1. Okay. Another interesting study which I came across, we talked about proteomics, metabolomics, something called as breathomics. So they actually estimated markers in breath of Hispanics, adolescents, and they found that these molecules, about 10 metabolites, were found to be significantly elevated in obese, pre-diabetic Hispanic adolescents. So this might come up as a future. It's a single non-invasive test where you assess for biomarkers in the breath of a patient. So what could be the future perspectives? One, first is glucose in unconventional samples. We've looked at saliva, tears, and now breath. Of course, they're still not standardized, but maybe 10 years down the line, it could be a whole different scenario. Radiology, I've talked only about blood, but we're talking about muscle fat. We're talking about liver fat. We're talking about pancreatic fat. These are new things. Estimating them is going to be a big marker to understand whether the person is at risk for metabolic syndrome and insulin resistance. But yes, as I said, the bottom line is still not out. We still need many more larger studies which, with rigorous clinical validation for its predictive power, both independently and in conjunction with the traditional risk factors. So what we advocate is there's no single gold standard, including A1C. We can, which is not like a gold standard for pre-diabetes, but probably look at the entirety, the holistic approach, where you're going to look at anthropometry, You're going to look at the risk stratification of the patient, ADL scoring for risk stratification, the anthropometry, lifestyle, and the current available biochemistry markers. So to conclude, pre-diabetes is a continuous pathophysiological process, heavily underestimated and a huge burden for full-blown diabetes. There's an immediate urgent need to identify more sensitive and precise biomarkers for subset of individuals with different underlying pathogenetic mechanisms, less personalized diabetes treatment, and combining biomarkers with clinical and established biochemistry parameters may provide a better sensitivity and specificity in predicting and preventing diabetes. Thank you so much.